Okay. So welcome everyone. This is our interfacility fireside chat. We have our subject matter experts on the phone, Dr. Tony Woodward and Lisa Nichols. And just as a reminder, if you could, please mute your phone or computer when you're not speaking so that we can try to keep the lines open so we can have a good discussion going on today. Briefly, our acknowledgments and disclaimers. Our usual IC has been supported in part by HSA of the U.S. Department of Health and Human Services under the following number. This information or content and conclusions presented here are those of us and should not be construed as the official position, policy, nor should any endorsements be inferred by HHS or the U.S. government. This is approved for continuing nursing education credits. Live session only. It was approved by the Emergency Nurses Association for 1 credit hour. I don't know where the, we'll post a link here in a second on where you can go. As a reminder, you have 2 weeks to complete the evaluation after today's phone call in order to gain the 1 credit hour. As soon as you complete that link, complete the evaluation, we will send you your certificate for your CE credit. As one more reminder, please mute your phone or computer. All lines will be open and interactive. Also, this call is being recorded, and if you have any objections, you may disconnect at this time. As far as our CNE credits, we need to disclose that we have no conflict of interest, and additionally, no commercial support has been received for this activity. Should any of the participants detect any bias in the presentation, please note such on the evaluation or reach out to Diana Fengia, our nurse for continuing education. And here is the link for the REDCap CNE credits. Use the QR code on the bottom right. We will send this out to you after the presentation as well for your So just a quick roll call check-in on who's on the line. How about let's start with our teams. Do we have anyone from Team 1? Providence, Western Kids? No? Okay, how about Team 2?
Hey guys, it's Terry from Cardinal Glen in St. Louis.
Awesome. Mocan Rocks, anyone from Mocan?
This is Cammie Townley.
Hi, Cammie. Anyone from 4? Kids. Okay, anyone Team 5, Lone Star Kids? No. Team 6, Fight or Flight? Team 7, New England EMSC? Okay, what about 8? 8 is enough. 9, Ready for Kids? Team 10, Pediatric Pit Crew? Team 11, Ramakmanans? What about Team 12, Whisper?
Hi, Meredith. Erica's here.
Hey, Erica. And what about Wranglers? Team 14, Oregon.
Hi, this is Amy with Permanente.
What about Team 15, Etch? And Pediatric Pits. Okay, anyone from HRSA or NEDAC on the line? Okay, anyone else I didn't call?
It's Waldy from Providence, Newburgh.
Oh, hi, Waldy. I'm glad you got on.
Yes, finally.
Good. Anyone else? All right. Okay, so this is our agenda for today. We're going to briefly go over our aggregate performance, and then our SMEs are going to talk about transfer delays and give a few suggestions on developing a transfer packet. And then we'll check in with each of our teams, and we'll do a little team check-in, kind of discuss any of the problems you'd like us to help you troubleshoot, any successes that could help other teams, and then finish up with a few housekeeping items. So with that, I think Lisa, you wanted to maybe do the aggregate performance, so I'll let you take over here.
Great, thank you. So, yeah, just wanting to go over, I'm sure you guys have all had a chance to go through and look at the scores that have actually been posted, looking at all the different people who have submitted data going forward on the interfacility transfer. So some of the things that we saw with in the data and stuff itself, and again, we did back on, I think it was like end of August or something. So there may be some updates and stuff from then. I did see a couple of changes, but nothing too significant. But just kind of taking a look at it as far as what we've seen and what we can really gain from it is some of the information that we want to try to be able to help with today. So the median time from arrival to transport and looking at that data and getting information, it was really helpful. We had sent out some questions. Meredith had actually sent out questions for us related to, you know, what are those things that are actually causing these times to be extended? And some of the information and stuff we'll kind of go over, talk about it in the next couple of slides. But I appreciate you guys sending things in because it's easy for us to say, oh, I'm sure that your problems are this, but it's nice to be able to hear from the sites themselves. And then hopefully we can try to help troubleshoot or actually think about ways that some of those things can be averted or potentially looked at a little bit differently. Looking at the transfers that met minimum criteria. So the minimum criteria, so, and I guess I would ask either Kate or Diana or even Meredith. So I know the minimum criteria, are those the 8 core components that were originally slated within the actual interfertility transfer?
So the minimum is actually defined by your site. So it's not about vital signs, but it has to do with what resources, patient capabilities you have at your site, or more important, which ones you don't. So if, for example, you had a patient who needed a neurosurgical evaluation and you didn't have a pediatric neurosurgeon, then that would be maybe a criteria for transfer.
Okay. Yeah, I guess the only question I have about that one, and that's part of the reason that when I went through and looked at these slides and in talking with Dr. Woodward as well, is every place is going to be different as far as what their minimum criteria is. But, you know, it looks like people are, you know, 84% of the time, we could be higher on it, but that's really doesn't seem to be as much of a focus because everybody's criteria is going to be a little bit different as far as what their minimum is. I think there are some things that are similar, so we can discuss that if you guys want to. But I think some of the other areas to focus on would be those patients who did not receive a transfer packet. And that's kind of one of the other things we wanted to hit on. So looking at the medium arrival time and then the transfer packets were kind of the two areas when Tony and I looked at this and looked at this data that we thought that we could actually potentially look at it and go from there. So next slide. This is just kind of the same thing, just getting the information and stuff, looking at graphs. It is interesting though, as you kind of watch the metric and stuff that has been loaded, you know, over time, that we've actually seen an increase. So the more people who are actually putting data and stuff in, it's actually been an increase in the time as we go forth. So that's definitely something that we want to try to see if there's something we can do to help in that area so that we can try to get that number to actually go down a little bit. Or are there things that difficult factors in which to really make that metric go down? And one of those things would be psych patients that are seen in the emergency department and waiting for beds. I'm not assured that that's going to actually make a difference from a time perspective, but are there different ways in which to kind of measure this data? So we're actually looking at those patients that need critical access and critical care at the time of transfer and making sure that they're getting out. Yeah, it's just one of those things in thinking about this as a different metric or a different way to look at it. The other things that you can actually see on here are the other things we've actually talked about. So the cumulative percent of transfers that actually met the minimum criteria, you know, that number has gone up, which is great. It's a really nice thing to see. So it's kind of one of those, we've talked about, there's been a significant change from that. You can see between June 9th and the 23rd, there may be more people who have put in information, but it went from 19 to 57% and has just continued to go up, which is a good thing to see. But the thing along the bottom that is concerning is that people are not receiving a transfer packet. So, you know, are there barriers to that? Are there things that we can help you with? We've given you some resources and stuff at the end of this presentation that hopefully you can take the information and be able to use it within your facilities as far as being able to create a transfer packet. Next slide. in wanting to look at transfer delays. So some of those causative factors that may lead to delay are part of what we wanted to talk about. We wanted this to be more interactive also. So as we get to a point toward the end, we can kind of open this up for discussion if there's other things we can help about. Looking at different discussions or case scenarios in particular that you've had within your institutions, where Dr. Woodward and I insight, or there can at least be a discussion, and other people across the country, within some of the other sites may have some different tidbits that would work as well. And then looking at that transfer packet context and how do we really work with receiving hospitals to develop those needed resources, so that when parents are actually being sent from one hospital to another, and it may be a city that they've really never spent much time in. So how do we make sure that they're comfortable and they actually know where they're going? So, all right, next slide. The causative reasons for transfer delays. Again, some of this was derived from information that was submitted specifically for this fireside chat, and some of it was from Dr. Woodward's and I's experience within both our institutions and working in different institutions. But sometimes a lack of predetermined guidelines can actually lead to chaos and some indecision when needed. And personally, I can give it an example of there was a hospital that is probably about 2.5 hours from here that never really sees children and definitely doesn't see critically injured children, who unfortunately had a child come in following a car crash. And as they told us when they called directly to the emergency room, they Googled our phone number and then were able to call the emergency department, which then, we put through our transfer center and then getting all the resources and stuff that we needed to. And unfortunately, there was an ice storm and other things that then ended up leading to more delays. But it's one of those things of, let me give you more resources so you at least know who to call that first step. Because there was like almost a 17-minute delay to be able to get into the people they needed to talk to, because they just didn't know a phone number. And again, it was a hospital that we didn't really get a lot of referrals from, and it was a very small critical access hospital. So just making sure that they have those resources and knowing that that's kind of going to be in a catchment area, that we need to make sure that we're getting that information and stuff out there as well from the main center. That's one. And then recognition to transfer that may be delayed. Sometimes you may get wrapped up in what it is that you're working on, or the child doesn't seem as sick when you initially are doing your assessments. And so there may be a little bit of a delay in recognition of, oh my gosh, this child has this. And so you're not able to you don't really think about transferring the patient until you get some either studies back or CAT scans back or whatever that might be. Another one would be no specific plan of where the patients will go. So those memorandums of understanding that are in, the interfacility toolkit that has been developed by the EMSC, great to actually give you some ideas as far as what you should get from a memorandum of understanding or those transfer agreements. And that's not necessarily to say that if you call a hospital, they're not going to say, of course, we'll take your patient. But it's really having that understanding of when I call, they know who you are, they know kind of what your capabilities are, and you know what their capabilities are. And I think those are very important things to know, is what are the capabilities of where you're transferring to, as well as what you're capable of. So having that memorandum of understanding ahead of time is very important. Delays with transporting services. So some rural sites may have limited access to EMS, and they have to rely on outside agencies or local agencies having to travel long distance. I know, again, that's another issue that we have sometimes here in Texas. Number one, they may only have 1 or 2 services in a small town. And if for them to travel 2 hours to our institution and 2 hours away from our, back to their institution and be out of their city for 4 hours, leaves no coverage. So then that becomes an issue as far as what's EMS going to do. And then in some rural areas that it may be up to 30 minutes before EMS actually gets on scene. So those are definite things that can cause a little bit of a delay as well. So being able to recognize upfront as best as you can, and having those kind of set criteria that say, okay, when we have this patient, we're going to call the EMS agency as soon as we can, and then get them moving while we continue to work through our processes and trying to figure out what's going on with the child, getting the institution called and everything else. Potentially calling EMS first could be helpful. Delay to getting an unnecessary or radiologic lab test. Tony's going to talk a little bit more about, not necessarily not doing any kind of treatments and stuff. But if EMS is there, you're ready to go, and the patient's stable enough to be able to transfer, then getting them on the road instead of trying to delay waiting for a lab test or waiting for a radiologic test, the actual results, you may be able to get that while they're actually in transit. And then again, as I talked about a little bit before, it's that lack of psychiatric beds. And that definitely seems to be a problem and an increasing problem across the country. I'd love to be able to solve that. Unfortunately, there are just not enough psych beds, unfortunately, for all of the issues and stuff that are going on with some of our kids today. But we can definitely have a conversation about how to tackle that. So, hi. Dr. Woodward?
Meredith, are you able to hear me okay? Okay, super. Well, I'm really pleased to be able to present with Lisa and want to thank Meredith, Diana, Crystal, and Kate for helping us prepare, come up with topics, and sort of get this discussion rolling. In reflecting on some of the data that Lisa presented, I think one of the interesting parts is that there's only been 11 programs through the middle of August that have participated in that data. So I worry that a little bit we're not getting a true view of the breadth of the group. So hopefully we can encourage others now that the summer's over to add more data and really allow us to see where the opportunities might be. Doing things well and getting positive attestations for that are great, but if we can figure out that there's an issue somewhere, just like we were talking about around the discharge or the transfer criteria, that might be really helpful. I'm going to go through some things that I think the people on the phone may be acutely aware of, but as this goes out into other organizations, they may not be as obvious, and I think reinforcing some of these things can be helpful. As we think about transport, although one of our metrics is how fast do you get the patient from presentation to transport, it's really, really, really important to recognize that speed alone is not. But that's the perspective of the receiving institution. It may not be the perspective of the sending institution who feels that they're overwhelmed, don't have the resources, have too many conflicting things going on at the same time, and their true goal is to get the patient away from their system as quickly as possible. And I see that kind of routinely in our emergency department transfer populations. I don't see that quite as often in our stable inpatient or progressively sicker inpatients, but more in our emergency department acute issues. So quality and stability, I think, really trumps the program, but it's not the only thing. And we can pride ourselves on being the best team around, but if it takes us 3 hours longer to get to a bedside than it would someone else as a non-critical care or non-pediatric team, referring folks are going to have a different perspective of how that works for them. And I think it's really a balance between those things. As we go through some of these criteria, and as you look through the toolkit, it talks about transfer criteria. And it really, as Lisa said, it's knowing what program capabilities are, knowing where the hard stops are, knowing where the soft stops are, thinking about progression when things progress, if they progress, how they progress, what am I going to do about that, and being ahead of that curve. And then our goal is to look at what we do and try to figure out what we can take out of this process. If it takes us, if we have to Google the phone number, that's a problem. We should be able to fix that. But if the person Googling the phone number is the unit clerk and the providers or the nurses at the bedside are the ones trying to make the content decisions, they might not even be aware that there was an issue. So having some quality discussions at the referring end can be very helpful. So as always, anticipate, preparing, reviewing, and then improving. Next slide, please. So there's reasons to transfer: trauma, medical, logistics, and otherwise. We'll go through a couple of these. Many of these are in the toolkit, but just to reinforce, having traumatic criteria, these are the patients that we can take care of. And remember, again, it's the lowest common denominator in a system that determines the ability of the system to manage the patient. You might have a superb ER team, but once they get into the inpatient environment or the ICU environment, it really is a drop in the level of supervision or level of care or level of pediatric expertise. So recognizing what's in front of you and what might happen will really help, whether it's trauma or medical. So the ones that are listed are pretty obvious. If you've got decreasing mental status, you've got respiratory stress or failure, you need respiratory support, you have shock in a patient that might need intervention, that would be really important to recognize and get the patient to a place where that can be managed in the most expedient and expertise fashion. patients who require blood transfusions, again, a marker for something more serious that might be going on. And then if you've had, obviously, to go into the really significant parts of invasive monitoring, intracranial pressure monitoring, or vasoactive medications, those patients probably do not belong in a hospital that does not have tertiary or quaternary care pediatric trauma capabilities. Next slide. Some of the anatomic criteria, and these, if you look at this list, it's really your level 1 transfer criteria list. If someone has level 1, level 2 trauma, and not at a level 1 or level 2 center, those are the patients that we need to think about ahead of time. We know about that from the mechanism, from what's reported to us, from what happened at the scene, and although some of those things have fallen out of our criteria, from our experience, we know that if there's ejection of kids at the scene, they're probably going to need more than we can provide at a non-trauma or non-pediatric trauma center. And then some ones that are maybe not quite as obvious. You know, fracture of 2 or more long bones can signify a much more significant injury. Obviously, head injuries, and then specific injuries like burns, eye injuries, genital injuries, things like that that really need some increased level of expertise. Next slide, please. How about the medical patients? Well, I think the medical patients are more common, perhaps, and not quite as clear. The trauma patients are a little clearer. If we follow our trauma guidelines, it's pretty easy to see where somebody falls out by mechanism or by presentation or by vital signs. Medical is a little harder because we don't always have a diagnosis. And the goal in transport is not necessarily to make a diagnosis, but it's to identify kids who are sick or have the risk of progression. So the medical patients I would think of transferring, and this is always a little bit difficult if you have the ability to take care of medical patients in your environment, but you're not quite sure if this patient's going to get worse, is look at how they are now and try to figure out where they're going. Sometimes that's really hard without a diagnosis, but if there's experience and expertise in the environment saying, you know, kids who develop this level of respiratory distress with this presentation have a 50% chance of going on to need positive pressure ventilation or things that we can't really do very well on a 24/7 basis, we should be getting those kids into an environment where they can care for them if they deteriorate. And obviously, any unstable ABCs, concern for serious bacterial infection as meningitis or sepsis. And I think one of the things I see missed occasionally are the sepsis kids. And we all have sepsis indicators now. We screen a lot of kids for sepsis. But if we don't get those fluids in and we don't get those antibiotics in and we don't get them to somebody who really knows how to manage that in a very time-efficient fashion, and that includes during the transport process, their outcomes can be worse. Obviously, you need surgical intervention if you need monitoring, or if you can't escalate on site. Those are important things to think about prior to the transfer. Slide. So initiation of transfers, it is a really important piece, and we mentioned the memorandum of understanding or transfer agreements earlier, but I think it's a complex process that sometimes is not quite as clear. Who do you contact? The memorandum of understanding or the transfer agreements can help with that, and if you only have one pediatric center in your environment, or you have a trauma center and a medical center and they're pretty clear, that's not quite as difficult. The transfer agreements will help you identify those things so that you don't have to think about it in the stress of an unusual but significant event. How do you contact that institution? Google's probably not the best way. There ought to be identifiable numbers that are readily available, but who has those numbers? It's usually not the providers, and again, it may not be the nurses at the bedside. It may be a shift supervisor, it may be a charge nurse, it may be a unit coordinator. Making sure that everybody involved in those situations knows how to handle this without spinning a little bit, and that will make that process a little easier. Who gives the report? Obviously, I think the best way to do that is have a provider-to-provider report and a nurse-to-nurse report. In my experience, seems to give the best picture of the patient to the receiving center. I've had one that was memorable for me where I talked to a provider and we thought we had a good understanding that the patient was relatively stable. It was an ICU type patient, but relatively stable. And the nurse-to-nurse conversation was a little bit different where the referring nurse said, "This is the sickest pediatric patient I've ever seen." And that really shed a light on me, as I didn't ask the right questions, or I didn't get the right information, or we were too superficial in our provider-to-provider presentation. So the nurse-to-nurse presentation really, really helped. And then how do we get there to take care of these kids? EMS is fine if you have the skills. Many of these are not pediatric, and you have the capacity, which is not always the case. Critical care transport team is always better to call early because it's a limited resource. It takes a while to get there. And then you want to know your teams and their capabilities. again, the fastest person to come to a system may not be the best for the patient, but it may be better than some other alternatives. So I think really laying those things out and identifying who are the people that you have an option to call in these difficult situations will help speed that process up and allow the providers and the staff to care for the patient and not have to worry about reinventing the process. Next slide. I think knowing who you're calling is really important. This is an example of a communication center. So when a call comes to this communication center, you know that you have their undivided attention in a place that has situational awareness of the region and of the hospital and of the bed situation. So it's much different than calling an ICU attending or a NICU attending or an ER attending or somebody else at the provider level who doesn't have all this. Also, when you make a call to a communication center, the processes should happen in parallel. If someone calls me about a transfer and they call me directly, I will take all that information. We'll go through the medical gathering information and advice. However, nothing else has been able to happen during that conversation. When a conversation comes into a communication center, it's often recorded, and the communication technicians can, or the experts can then be able to get transporter range, check on bed situation, look at alternatives if necessary, and get all the other stuff going that needs to happen as well to make it a seamless transition from referring hospital to the transport system to the receiving hospital.
Tony, this is Lisa. Can I make one comment on that?
Yeah.
I think what you just said is really, really important, and I think it's something that we don't always think about. It continues to be a problem in many different institutions, and that is phone calls come into everywhere. They may call directly to the PICU because that's the only number they have. They may call directly to the NICU because that's the only number they have, or they call directly to the emergency department. But it truly is important, and it sounds strange, but it truly is important to get to that transfer center, because I know, for instance, in the institution that I work in, and there are other institutions that I've been a part of as well, that as soon as you call into that transfer center, their transport team or their critical care transport team are also getting on the call at the same time. And so they know exactly what's going on, and they need to be able to deploy their team before you've ever actually have been able to talk to an emergency room physician. So it does save those critical minutes if you're actually getting ready to make that transfer. So it's important to make sure that you're calling the exact right number and that the access hospitals know exactly what that number is, to try to get around that, calling the wrong people. The other thing that I would say too is, and again, it depends on the hospitals and stuff within your system, but making sure that, so we have the problem here that unfortunately there's Dell Children's, and then there's now Dell Seton, which is the adult level 1 hospital. So sometimes people will say they want Dell. So that's very confusing. So it's being clear on which hospital it is that you want to make sure that you're talking to if you're calling into a hospital system. So just a side note, but.
Thanks, Lisa. I think that's really important. One of the things we did as we built transfer centers in the places I've worked is the calls would traditionally come by a lot of circuitous routes, and then we had to talk to our staff internally and say, if you get a call like that, either redirect it to the communication center or tie in the communication center so we can put these things all together at the same time. Because from the outside perspective, it's much quicker to call a provider quickly and say, hey, I know you from when I was a resident or when we were faculty together. I need you to do all this. And they don't quite understand all that stuff in the background that has to happen to make this process work. So your options for pediatric transport, often the quickest is no medical provider, but usually not the best in the kind of patients we're talking about. EMS is often used as a surrogate for interfacility transport. You have to be really careful with this around the pediatric component, and we'll mention that in a second. And then our interfacility transport teams come in the specialty and the non-specialty variety, and they're expensive, and as we all know, they're quite resource limited. So when you look at I'll go next slide. When you look at your transport capabilities, and I think even though this seems like common sense to many of us, I found out in my own institution that this is not common sense outside of the EMS world or outside of the ED world. So helping our ICU doctors and our NICU doctors understand, and our other providers and some of our medical command physicians, as well as our staff, understanding these subtle differences is really important. So BLS, it's a obviously 100 hours of training, not a ton of medical expertise, not a lot of pediatric expertise or experience, and can't do a lot on the transport. Paramedics are amazing. They have, 1 to 2 plus 1,000 hours of training. They're able to respond in critical care situations in a tremendous manner. They can do interventions and they can do a lot of acute care stuff, but they may not have a whole lot of pediatric expertise. We know that only 15 to 20% of their kids, of the patients they transfer are kids, and only 15 or 20% of those are sick. So recognizing that while the training might be great, the experience over time might not be as robust. Critical care ambulances, the same as the paramedic ambulance with the addition of a critical care nurse. This can really add to the skill set of that particular ambulance. However, in some of the environments I've been aware of, this critical care nurse is not pediatric, so it brings critical care nursing skills, but perhaps not the same skills that a pediatric intensive care provider might have. And then the critical care transport teams, I think, when they're able and available and they have the capacity, are really the best, because with a phone call, you can start critical care transport at the moment of the phone call. You can continue it and assess it when the critical care transport team arrives. And that should raise the level of care throughout the process and not allow the care to drop at any point, so that they get to the tertiary or quaternary care center in the same or stable condition, as long as there's not progression of the disease process, which was unavoidable. The next slide, please. Our responsibilities on the referring end, when we refer, is really to anticipate and prepare for what we think might happen, and don't be afraid to pull the trigger a little bit early, make an appropriate decision to transfer, stabilize and prepare the patient prior to transfer, and that means doing the things that are really important with the ABCs. And I would say probably the most routine thing I've seen in our transport world is where a patient is kind of a tweener. They're relatively sick. They could use some intervention, but the referring facility may not have as much information or experience with kids, and says, I'll just wait till the transport team gets here and then they can do it. Well, if the transport team is 5 minutes away, that's probably okay. But the realistic is they're often hours away, an hour or 2 hours away, and you don't want that patient to be in a corner deteriorating while the expert arrives. So if things have to be done, then figure out how we can do those. Figure out what can be done prior to transport. Not only do we look at how fast it takes to transport a process or to make a decision, we look on the transport side of how long are we engaged. And if we go to a facility and we spend 60 minutes retaping lines or making sure things are putting in a second IV or stuff like that, it makes it a little bit more difficult. So trying to anticipate what might this patient need and how will they be the safest in the environment, and then paving that way for a very efficient transfer is helpful. Part of that is being available, and that's not always the case because the folks who are referring often have a lot of other things to do. But there should be no tension between the referring and the transport team. There should be no concern of, I didn't do things exactly right. If you didn't or we didn't, that's fine. We'll learn for it for the next time. And then, as Lisa mentioned, don't delay the transport to do a lot of stuff that can be done somewhere else that might be repeated anyway. Choose the appropriate transport process and destination, and then have your consent for transport, making sure that it's very clear where the patient's going and by what mode, so that the mode or the receiving team gets there and doesn't have to stop what they're doing because the family now disagrees with the plan. Next, please. And then the receiving hospitals on the end of the receiving is, one, they have to have immediate capability or availability when contacted, and ideally that's through a transfer center. They have to accept the patient if they have capacity. They should give clear, concise, and expert recommendations, which is often not a core competency in physicians. It's not something that we're necessarily taught in medical school. So learning how to have an efficient medical communication, like an EMS communication, is important and really relevant for us. Prepare our team so we don't start from scratch when the patient arrives. So if they needed a CT or they needed a surgeon or they needed the ICU or they needed a drip that wasn't available prior to that those things are ready. We don't start from scratch when the patient shows up at our door. And then communicating back to the referring team in a way that's helpful. It's not to say, hey, you should have given this kind of fluid instead of that kind of fluid. It's talking about the opportunities to work together to make sure that the next patient who comes in has the optimal care based on whatever scenarios they present with. Okay, next slide. And Lisa, I think you're going to go from here.
Yeah, thanks, Dr. Woodward. So a lot of these slides and stuff that we've gone through, I know that we're kind of going through them quickly and a lot of this information, but I don't know that a lot of this information is new to you. But we really wanted to spend a little bit more time on transfer packets and being able to potentially provide you some resources that you could actually then take back either to your institution and or to some of the transferring institutions that you're helping to work with. So, but it's important to know, so where is the receiving hospital? So directions are how to get there and where to go once they're there. So there are a lot of people who come from a rural setting who may not really have ever been to whatever that large city it is. Or if they are coming there, that they truly don't know how to get there and what's the best way to get there. So I always go back to my own mother, who we only lived an hour away from a city when we were growing up in a very small town. But even when we would get close to that city, she didn't want to drive and would not drive. And so she would always have somebody else drive her once she got to the city. So it's very intimidating for people, and it may be very intimidating for the family. So it's important to make sure that they at least know where they're going and what's the best route in which to get there. And then what are those transportation options? Will EMS or the transport agency allow a parent to ride with them? It's important for that parent to know before the transport team actually gets there kind of what the expectations are. And that's developing relationships with your EMS teams, whether they be your local EMS teams or knowing kind of the people who are coming, if it is a critical care transport team or an ALS team or whoever it is, what's their expectation? And will there be room within that ambulance and stuff for that parent to be able to come with them? And then if that happens, what type of resources are they going to need on the other side? And making sure that you share that information except with that the receiving hospital as well. Are there any hotel or lodging options close to a hospital? So if it's a children's hospital, many times there is a Ronald McDonald House or something equivalent to that that's close to the hospital. And sometimes if you can get the information ahead of time, especially if it's like more of a late afternoon or evening, if we can get that information ahead of time, it's easier to reserve a room, that family that may need a place to stay for that night, than it is if they get there a little bit later. It just really depends. But sometimes even being able to tell people, hey, the parents might need, some sort of an accommodation, or there's 2 parents coming or whatever that might be, and letting them know kind of what those options are as they get close. And then some contact information. We try to get as much as we can. We try to get 2 numbers from families if we can, if that's a mom and a dad's cell phone, if it's a home phone, if it's, whatever it is, but at least trying to get 2 different phone numbers and stuff so you can actually get in touch with people as they're coming to see you as well. Because oftentimes the child will arrive before the family does if they're not able to ride with the family. And then somebody to greet the family on arrival at a referral center. So it's important on our end to make sure that we know when the families are coming. And even, if you know the parents' names or just kind of where they know that they need to go, that they're supposed to go to the emergency room entrance or they're going to the main entrance or wherever that may be, so that then the referring hospital can actually have someone there to actually greet the family. Because there's nothing worse than you're coming in and concerned about your child that you haven't now seen for 2 hours because they were in transport and you're not exactly sure who it is that you're supposed to talk to. So the referring hospitals, thinking about who is that person that's actually going to be out there to greet that family and make sure that somebody's available to be with them. And next slide.
We're losing you there a little bit.
Lisa, we're losing you.
Okay.
There you go. Now we can hear you. If you could jump back just a couple minutes. We missed you for a few minutes.
Sure. After where were you to Hotel Logic or before that?
Yeah, I think you had talked about directions and transport options. I think we could hear.
So all I had talked about with hotel and lodging is many different hospital institutions have a Ronald McDonald House or some facility that's like that, that's close to the hospital. Recommendations would be if you could hospital, in nurse to nurse report or something, and letting them know that the family's coming, that they may have needs for a place to stay. There's smaller children, something else that's coming with. Sometimes if you can give them a little bit of heads up, it's also easier to try to get a reservation and stuff in those places. The earlier the better. And or if there's a hotel that's close by, kind of a similar thing. Sometimes it's easier to get a reservation the sooner you know. And then the 2 phone numbers is really recommended. It's much easier if you know 2 different numbers in case for some reason one isn't working. It's always nice to have a backup. Or sometimes you may not actually have the right number. Somebody may have given you a 1 digit off. So it's always helpful to have more information than less. And I talked a little bit about making sure that there's somebody at the referring hospital that's there to greet the family and that the family knows what door to go in. So is it that they go into the emergency room entrance? Are they supposed to go into the main entrance and somebody's meeting them there? But be very specific as far as where they're supposed to enter referring hospital to know that, you know, here, Mr. and Mrs. Smith, you know, are going to be coming to this entrance, and so that there's somebody available to be with them and help them with resources as quickly as they can. So next slide. Sorry. This is just an example, and I know it's very, very small print, but it's just a template for kind of an interfacility transfer checklist. So, and it's those kinds of information that you want to make sure that you're sending with your patients from the outside referring hospital, so that that kind of information will be readily available. This is kind of what Dr. Woodward was talking about, as far as these are some of the things that you can kind of check off as you're waiting for the transporting agency to get there. That, you know, intake and output, make sure it's done. Copy of the medication administration record, logic reports, making sure that you have a disk available, or if you have a cloud that you can push the films to, that's already been done. Copy of any vital signs or ED records, all of those things, and making sure that you're having all of that done, so that then you can actually give all of that, you know, to the transporting agency as soon as they get there. You're not waiting to copy off everything once they get there. You may have 1 page left to copy because that's your, you know, MOT or one of those kinds of things. But other than that, you can get a lot of things already ready to. Kind of at the bottom, you'll see that there's, you know, family was given written directions to the facility. They're giving a phone number of a receiving unit or the emergency department. And then you have specific information on here. But this is just an example of something that's actually used in Washington State. But you can make something similar to this, but it's a nice thing to have as a checklist for any patient that's being transferred out. So next slide. So this is another example. And again, thank you, Dr. Woodward. He shared with what they actually do at Seattle Children's to kind of give you an idea of some of the quick tips at outside facilities that they can be used to kind of give them an idea as far as what different information they can tell them a little bit about Seattle Children's before they get there. Kind of what the different areas and stuff are. They have a family resource center. They have an inpatient playroom. There's a teen zone, a therapy pool. There's, you know, child life specialist, and a little bit about what that is. And about, you know, detailed information about, you know, before you get here, you know, where's a place to stay. The unit brochure that's in the packet you'll be given when the patient gets there. So you'll be told a little bit more about the actual unit that you'll be on. So next slide. And then some of the other general information about, you know, how do you get around? So how do you get around the hospital? So if you're going to be staying overnight, information about it. What are the sibling visitation rules? But this is a very detailed and very helpful piece of information for parents that they can actually have. So it's those those hospitals that are referred to, that the receiving centers that can actually provide this information in a brochure and getting it out to those hospitals that are referring to them, so that then families can have this information and they're not wondering, you know, what types of things and stuff they need to know once they get there. So this is a really very useful and very helpful guide. Next slide. So this is just one more thing that's also in the same thing. It kind of gives driving directions. And again, depending on which way you're coming from there. So what types of things do they need to know? So, you know, these things are incredibly helpful to parents, again, if they've never ever been, or they may have been there before, but they're not exactly sure where the hospital is. So next slide. So other resources are out there and are available. So the Trauma Centers Association of America actually has some pediatric trauma interfacility guidelines within their publications as well. So if you're a member of TCAA, or some of the facilities that you work with are members of TCAA, they have some interfacility transfer guidelines also that are available that you can download and kind of, you know, make them your own, but use some of the components within there. Kind of gives you ideas of what other people use or what parents might need in transporting patients. And then the interfacility toolkit is a great resource. It's been a great resource since it was developed. And there's lots of good information and stuff in there that kind of tell you about what types of things to put in a parent packet, and having those things readily available to make that transition that much easier for those parents the time that they're really not ready to, leave the town that they're in, and they don't really have any resources for themselves. So it's nice for them to know what's going to be ahead of them once they get there. Next slide. American Academy of Pediatrics is also another guide that you can use. They have some evidence-based airport and transport guidelines that kind of will tell you within a transport itself, what can you expect in the care of the child that's actually happening with that. And there are other great resources and stuff within either one of those guides. So we wanted to be able to provide you some resources that you can use in developing your own resources for each individual institution, which may be a little bit different, depending on the capabilities of that institution. Next slide. So in summary, we just want to look at assessing your facility and staff to pre-identify those patients who should be transferred. That's really key, and knowing what are your capabilities and what are not your capabilities. So the minute you see something that you can't take care of, that you're ready to be able to transport that patient as quickly as possible. I'll tell you, I mean, even at, Adele Children's, where I currently work, if we have a patient that comes in, recently, we've had patients and stuff that have more significant burns. That's not our forte, and that's not something that, as long as the child has a stable airway and there's not other issues and stuff with the patient, that's not something that we're really great at taking care of, and we're not the experts of it. But there are burn centers that do that. So if it's a more significant burn, so then we're getting the transporting of that patient put together and getting them out of there as quickly as we can, because we know that we are not the experts in doing that either. So it's really important to kind of know who those patients are and having that list of it. Assessing and reassessing the process. So that's kind of where all this data collection comes in. You're always looking at the process and making sure that on feedback forms and talking with parents and giving them evaluation forms, that you're adjusting your program and or your resources based on what it is that you're learning from those families and or the facilities themselves, whether that be the receiving or the referring hospital. And then consider where to care for your patients ahead of time. Are they capable of caring for that patient? And then who can help you? Who can help you with that process? Are you capable of caring for the patient? So knowing that ahead of time. Considering what to give families, what you're transferring, what do they need to know? And then that evaluation that I talked about a little bit. And then feedback of the receiving institution. It's incredibly important. And I like that somebody had sent this in the questions that we had. It's important that you're actually providing feedback to that sending institution. Because sometimes, they send a patient and they never hear anything. And there's nothing more frustrating to know than to be like, I don't know if it went well. Were there things we could have done differently? Plus, it's just nice to know that the child got there safely. Or if there were any, concerns and stuff about the care, or there were things that the child ended up doing fine. It's just helpful to be able to provide some feedback and stuff to those institutions in a fairly timely manner. They kind of work on their processes, praise for the care that they actually provided. I think is not me. So we wanted to have a little bit of time, and I know that I do mean a little bit of time, to kind of open this up. And if there are other questions and specific things that we haven't had a chance really to kind of tackle within this talk, we really wanted to have a little bit of time to try to help answer some of those questions. Anyone can shoot anything out there. Either, I don't know if they can unmute the mics, or we can send in questions, either way.
Yeah, the lines are open. Thank you, Lisa. So anyone, if you want to comment, so the list here I have is really who has entered data as far as their facility transfer. And if you want to speak to any challenges you have or any of the comment transfer abilities or anything that you would want advice from our wonderful subject matter experts, and to that.
This is Terry from Team 2. Lennon, because we are but we don't have inpatient psych. Most of our transfers out of our facility are for psych. Big delay that Mary and I have discovered is the intake process, and then finding facilities for those kids. That's been our big challenge. Now we've been very fortunate. It's kind of timely that after we entered all our data, again, most of which were psych transfers, our facility, our hospital initiated a telepsych program probably within the last 2 weeks. So that's kind of our change intervention, and just to see how that decreases either times decisions, whether or not these kids are discharged or wherever their disposition is going to be. affecting it if we have to transfer to a different facility for their help.
You know, I think you identify really challenge. Psychiatric patients are different than medical and surgical patients with regards to who can accept them, what systems will take their insurance policies, how long they can stay, what ages they are appropriate. Are they under 14 and we won't take them? Are they over 18 and we won't take them? I think you're not alone in that challenge. The telepsych should help a little bit with maybe more efficient evaluations and ability to figure out where they're going to go, but huge issue with a limited resource, and I think we're still going to see delays in that area until we can figure it out. And my sense is it's not so much the transfer system delay or the transport system issue, it's a delay on the receiving end by not being able to accept, not being able to send.
Absolutely.
Yeah, I guess the only other advice I would give is, and, you know, I know when you're setting up your telepsych that you have like a specific time frame and specific metric that you're looking at as far as evaluation of those patients via telepsych, you know, that they're there for, you know, 4 hours, or they're there for 8 hours, or they're there for however long that they're there, that you actually have something set up ahead of time that at that mark is when they will, you know, you'll evaluate for how that works.
Right.
And then you can revisit it on a timely basis so that you actually have something set up ahead of time.
Anyone else on the line?
There's a question in the chat box. What's the role of insurance authorization in the process? Parties run into barriers here, and what type? I don't know if or Lisa, if you can comment on that.
No, I don't see that question. Could you repeat it? I couldn't quite understand you.
Sorry, it's what is the role of insurance authorization in the transfer process? And has anybody run into barriers around that, and what type of barriers, if any?
I can talk from the receiving end that if it's a stable patient and they're transferred without an escalation of care, there will be an insurance ramification. And if it's not a preferred provider or not a place that the family has an insurance relationship with, they'll be stuck with a huge bill, not only for the hospitalization, but also for the transport process. You know, we certainly see a lot of our air transport systems do financial triage on those stable patients to make sure, you know, this is going to be a $25,000 transport, who's covering this, to make sure there's financial resources to do that. I haven't seen that be an issue with acute care transfers, but others might have had some situations like that.
I've definitely seen it with, as Tony Woodward alluded to a little bit, there's the, if you have got a specific kind of that puts you into a specific health system, and then being transferred out of that health system can sometimes be a barrier, and the families may be stuck with that bill. Now, it may be different because of an acute care facility in that situation. If it is something that's critical and it's not available at the other facility or the other system, it may be covered for that part of it, but then you run into the problem of when you get in for critical, you know, care of that patient, you know, what gets covered and what doesn't. Within your memorandums of understanding that you know what system they may be in, and then understanding within your own systems, or if somebody comes in with a different insurance, that it may not be covered.
For that.
Yeah, I'm going to chime in with one of the things we talked about this talk kind of from the receiving center perspective, and talked about making sure that, you know, we give our referring centers the right information. But I think one of the really important parts to make the system work better is getting information from the referring centers back to the receiving centers or back to the transport system. We often don't know how well we're doing unless somebody says, hey, you know, your communication wasn't so great, or you were condescending, or you didn't come when you told me you were coming, or things like that, that allow us to look at the system that serves the tertiary care referral transport system and say, how can we get better? So it's a two-way street with communication, and getting permission to do that, I think, is not always easy. It's certainly hard to get feedback in the moment, but make a clear feedback plan for both the referring and the receiving institutions, I think, helps make us better in the long run.
Hi, this is Erica from Wisconsin. So we have one of our hospitals working on this bundle, but my question is a little bit more general. I know I've been some time reviewing the interfacility transfer toolkit, and there are a lot of templates for interfacility transfer agreements. I'm wondering if there's any resources identified that are templates for complete interfacility transfer guidelines with the 8 components. Based on the subject matter experts' presentations, I realize there is a lot of, really a lot of personalization that has to go into this based on the capabilities of the hospitals. But I'm wondering if there's any good templates that have been identified.
Erica, there's an interfacility transfer toolkit that's on the EIC website that walks through all of the various components of building an interfacility transfer packet and what to think about and how to begin to customize it to your individual institution. So that would be a really great starting point. That was a product that actually I think Lisa contributed to, Fenja Snow, among many others years ago, and Tony Woodward, and it would be very helpful, I think, to review if someone's struggling with that.
I think it's unfortunately pretty individualized. There's lots of resources that, and the AAP guidelines has been very helpful as well with kind of setting the parameters, but I don't know of a specific checklist that's been universally accepted.
Okay, that's really helpful to hear from both of you. Thank you.
All right, any other questions, comments? Okay, well, with that, I'd like to really thank Tony and Lisa. Thank you so much for your input and taking the time to put these slides together. As usual, the recordings will be posted to the website. Any last questions, comments? And with that, we can let anyone go. If not.
Thanks so much to Tony and Lisa for that great presentation. And this will be posted, of course, on the website. So for those who might not have caught all of it or hoping to share, there's lots of great information about choosing minimum criteria and thinking about the transfer and how to create them and what might be included. So please feel free to review that. But thanks, Tony and Lisa, really your time and dedication to this.
Thanks, everyone. Always a pleasure.
Thank you.
Thank you.
Take care.